Hello, everyone, and thank you for joining today's webinar, Autistic Adults and Other Stakeholders Engaged Together, AASET, for Suicide Prevention. Before we get started, I'd like to go over a few housekeeping items so that you know how to participate in today's event. To the right of your screen is the control panel. As an attendee, you have the option of listening in using your computer or by phone. To switch from computer audio to phone, just select telephone in the audio panel and follow the dial-in instructions. If you're having trouble hearing me, please send a message through the questions pane and we will assist you. At the end of today's event, you will receive a certificate of attendance via email. Since your mic is muted by default, you can submit questions to our presenters by typing them into the chat pane at any time. We will hold off on answering any questions until the end of the presentation. All right, since most of you are probably here now, let's go ahead and get started. So my name is Rachel Polanski, and I am your host for today's event. It's great to have all of you today. I have the distinct pleasure of introducing today's speakers, Dr. Stephen Shore, Teal Benavides, Brenna Maddox, and Sherry Yeager-Hyman. Dr. Stephen Shore is a clinical assistant professor at Adelphi University and board member at OAR. Dr. Teal Benavides is an occupational therapist, associate professor at Augusta University, and member of OAR's Scientific Council. Dr. Brenna Maddox is an assistant professor at UNC Chapel Hill and OAR-funded grantee. Dr. Sherry Yeager-Hyman is a clinical psychologist and assistant professor at the University of Pennsylvania. The AASET team's goal is to comprehensively prioritize specific positive health and healthcare outcomes desired by autistic adults, identify potential evidence-based interventions and best practices, and to engage stakeholders in collectively implementing the prioritized interventions through patient-centered outcomes research. So without further ado, I'd like to turn it over to the AASET team. Take it away.
Wonderful. Thank you so much, Rachel, for that nice introduction, and a big thanks to Stephen, Teal, and Sherry for being here today with me for this co-presentation. I'm going to kick us off, and you're going to hear from all of us today. So thank you all for being here, and a big thanks to OAR for the opportunity to present on this shared work. So first, we want to lay the groundwork and share the overall objective of this presentation today. Our goal is to describe effective practices for meaningfully and authentically including autistic individuals and their family members as research partners. And throughout the presentation today, you will be hearing us use identity-first language, so referring to autistic people or an autistic person, as opposed to first-person-first language, which is in congruence with the preferences expressed by our collaborators on the spectrum. So most of today's presentation will be focused on strategies and our experiences with engaging autistic individuals as research partners. The particular research study that you'll be hearing us talk a little bit about today is funded by the Patient-Centered Outcomes Research Institute, or PCORI, and it is focused on suicide prevention for autistic adolescents and young adults. We don't have time to go into much detail about this study today, but we are happy to answer any questions, and we will also share a link to more information about this study on the PCORI website. The main purpose of this study is to compare two different brief interventions for suicide prevention that have been tailored for autistic individuals. They are both a modified version of the safety planning intervention, and we're comparing one without a follow-up and one with a structured follow-up. And our study questions are listed here on the slide. It's primarily an effectiveness study, so we're interested in which approach results in better outcomes for autistic individuals. We are also interested in implementation outcomes, so acceptability and feasibility of the different treatment approaches, both from the lens of the autistic individuals and also from the clinicians and clinic leaders. And then we'll be looking at which factors impact the effectiveness of these interventions. So this is a 5-year study that we just started in January. So you're going to be hearing today about a lot of our work together as a team from the very beginning when we were working on that letter of intent to PCORI, all the way up until today, about 4 months into the study period. This is a kind of overwhelming slide, lots of text here. And we're not going to go through each and every one of these words by any means, but we wanted to give you an overall view of the large and very impressive study team that we have the amazing opportunity to work with. So we refer to ourselves as the AASET SP team, autistic adults and other stakeholders engaged together for suicide prevention. And you're going to, again, hear from Sherry today and also from the co-leads of our stakeholder engagement core, Teal and Stephen. One thing that we do like to highlight from this slide, anywhere you see the superscript blue A here on this slide, signifies an autistic collaborator or a family member of an autistic individual. And so we are very fortunate to be able to partner with autistic individuals and family members across multiple roles for this project. And then we also have the opportunity to partner with a multi-stakeholder advisory board and dissemination stakeholders as well. Now I'm going to turn it over to Stephen so you can learn a little bit more about AASET.
Okay, so what brings us together? A number of years ago, I had presented on a panel focused on autistic strengths at the at INSAR, International Society for Autism Research, and I was accosted by this OT who had this crazy idea about studying health priorities for autistic people. And while we thought we might be able to write a good paper and even get it published, wouldn't it be so much better if we asked the autism community? And would it be even better if we engaged the autistic community in the research itself? So that is exactly what we did. We proposed to PCORI to study exactly that. Seeking health priorities for autistic individuals. And the co-leads were comprised of one diagnosed autistic person and the other doesn't have a diagnosis. Then we set up a community council of mostly autistic adults with some other stakeholders such as family care partners, educational institutions, and so on. So our goal, to identify priorities for research desired by autistic individuals, and then to share these priorities and priority outcomes with the research and practice community. And what we identified is that access to mental health was most on the minds of autistic individuals, which led us to the work that we're doing today. So I will now turn you over to Brenna.
That's right. Thank you, Stephen. That's such a great lead-in to how the letter of intent process and the full PCORI application process got started. A collaboration with AASET and with Sherry and myself. So back in 2020, we started getting some ideas together to respond to this call from PCORI for the suicide prevention funding application. And AASET members worked with Sherry and myself to revise the research questions, to identify the priority outcomes for the study. We were lucky that AASET already had done a lot of that kind of groundbreaking work to understand what are the priority outcomes when it comes to mental health for autistic individuals. So we were able to draw on that literature that they've published and then have discussions as a team about what are the priority outcomes for this project. We talked a lot about how can we create opportunities for authentic autistic involvement in different types of study roles, depending on people's interests and their time availability. And we also discussed how to make sure that our methods were congruent with autistic priorities. So how did we do this? A lot over Zoom. So luckily we had all been practicing with Zoom before this point, a silver lining of COVID, and AASET members are across the world. We have international collaborators from AASET, and so Zoom came in handy for those meetings, and we typically would have different meetings at different times to accommodate for various time zones. So same agenda for the meeting, but multiple times. And then we would follow up after the Zoom meetings with voting for key decisions through Google Forms, on any sort of choices that related to the study design. We had a great amount of email correspondence, and you'll hear some more from Stephen in a minute about how we structured those emails. And then we also talked with AASET about organizational partners and other members to invite to be a part of the project. And you saw a lot of those organizations listed on the previous slide as part of our dissemination stakeholders. So what changed as a result of AASET input? So, Sherry and I came to the table with some ideas based on our previous work and thinking about the safety planning intervention for autistic individuals. And we came to the table and learned about a lot of things that we had not been thinking of and things that we should add in. So here are some of those main examples. We were originally planning on assessing our primary and secondary outcomes with mostly quantitative methods. And for example, we heard from AASET that for quality of life in particular, it's going to be really hard to capture that comprehensively with a questionnaire, and we needed to add some interviews as well. And so we now have a more comprehensive qualitative component as well to our outcome assessment. The secondary outcomes include those priority outcomes that AASET identified in their prior work. We also, for our outcome assessment team, we talked about a really wonderful recommendation to make sure that every interview that takes place with an autistic participant is co-led by an autistic research team member, so an autistic interviewer. And so we made that adjustment to the proposed methods as well. Those same autistic outcome assessors who are conducting the interviews will be part of the qualitative coding and analysis. We had other changes that we don't have time to discuss today to really promote the acceptability and feasibility of the methods for autistic individuals. We have our clinician training team co-led by an autistic partner, and we also heard this great idea that we need to have a study staff training team to train the research assistants and the project coordinators about how to effectively communicate with autistic people, and that team is also co-led by an autistic collaborator. And then, as you'll hear a little bit more about today, we have ongoing assessment of our engagement practices because we know that we still have a lot to learn, and we want to get feedback throughout this process about ways that we can improve. I will now turn it back over to Stephen.
So let's get a little bit into how we authentically engage autistic individuals in research. And in doing so, we published our compensation engagement guide that you see right here, which is available at the link below. And in this guide, we focused on what we call the 4 C's of competence, communication, compensation, and considerations. So on the next slide, let's take a look at competence. And it's what we're doing is we need to destroy the myth that individuals who don't speak are less intelligent than those who do. There are many autistic people I communicate with via assistive communication devices, and the only reason that I know that they don't speak is because I've met them, or they told me, or somebody else told me that they don't speak. People who don't speak, who are non-speaking, which we prefer to use rather than non-verbal, have the same range of intelligence as everybody else. So it should be assumed that the non-speaking person understands everything that is being said. We need to turn away from a deficit-based model of talking about sensory dysfunction, for example, and talking about sensory differences. And even ASD, reframing ASD as autism spectrum difference. And even though these differences may impact function, we focus on how we can overcome the challenges and make accommodations for those challenges. So one example is that when we communicate with the person on the spectrum, being with that person, we should not talk about them as if they're not in the room. if they're with us. And again, listening to deficit-based language is detrimental to a person's mental health. On the next slide, we have communication. So as Brenna mentioned, this is how we communicate. Prior to using this model for communication, we had very low responses to email requests from our community council. But once we clarified how we communicate that minimizes verbiage, we found that the response rate went up to 90 to 100%. And what you see on the top also is what is good for the goose is good for the gander. And what that suggests is that while we may initially start out developing strategies and accommodations for exclusively autistic individuals, it turns out that everybody benefits. Everybody tends to benefit from these accommodations. Everybody appreciates clear and concise communication. Compensation. Essentially, this can be summed up as equal pay for equal work. If we're going to ask an autistic person to speak at a conference, to proofread writing, or in any way be involved in our research, they should be paid the same as anybody else. And we're making sure of that. We've managed to increase the pay for autistic people being involved from $50 an hour, as we recommended, to $100 an hour in our current research. So now I will turn you over to Teal, who will talk about considerations.
Thanks so much, Stephen. So our last C in our engagement and compensation guide is really thinking about how we can continue to measure and build the trust, respect of our autistic partners in this research process. And one way that we really want to know if we're doing a good job at authentic autistic engagement is whether or not our partners feel that they're able to bring up different ideas and concerns to the study team. In order to have a meaningful dialogue about how to change current research and practice, we need to have trust in one another, that those ideas are respected, valued, and that they'll be acted upon in a collaborative spirit. And so one way that we measure this is we identify, are people bringing up concerns in meetings? Are they bringing up questions that help us think differently? Are we able to bring up questions and concerns in return? Do we have this bi-directional trust and communication that allows us to have these meaningful and important conversations? And so trust is a really important factor in all that we do. A second main consideration to know whether we're doing a good job at authentic autistic engagement is ensuring respect. This includes making sure that contributions are valued and that people on our team feel that their contributions are important and contribute to changes in all of what we do. And so we can understand or measure this by making sure that we have an equality of voices in meetings and decision points. So who's doing the majority of the talking? Who's contributing to the process of decision making? We really want to make sure that the balance of power is shared and that people feel that that balance of power in the research and study decisions is appropriate. We also want to make sure that contributions from our stakeholder partners are included and recognized in all of our process and products. And so when we, for example, give this presentation, one of our members from our AASET Community Council, Alicia Ashkenazi, shared with us the email template that was developed in her work with Aspire. And so that's one place where those contributions are recognized and we name our authors on all of our products
as people contribute. And the last way that we might want to consider measuring authentic autistic engagement is whether or not we're implementing various ways and processes to support engagement. So are we offering different ways to communicate needs or participate in meetings? Or are we only offering one way? We try to engage people by providing both a video and chat-based option in our meetings. We also encourage and support having one-on-one meetings instead of group meetings if people prefer or feel more well-supported in a non-group setting. We also support and value other ways of engaging autistic partners. So for example, in our group meetings, we have closed captioning, or we have a live scribe who's taking notes while the meetings are going on so that people can follow along with written text on another document if that's preferable. These are some examples of support options that we've asked our autistic partners to share with us and that we incorporate into our study activities. We continually learn about this, and so we know that we're going to continue to make changes as our team grows and learns. So what do we recommend? And to summarize what you've heard so far, the first is to include autistics in the development, implementation, and dissemination of research. It's not enough to ask people what they think at the start of a project and then take those ideas and run with them. Autistics need to be involved in every phase and aspect of a study. Second, ensure participation through appropriate accommodation. This includes asking people what they need and following through with those supports. Third, presume competence and focus on abilities in all interactions. Ensure that partners feel that their strengths are supported and recognized and that they're a well-supported match for the role that they're in. Value autistics as an integral part of the team, avoiding tokenism and just having a name on a piece of paper. Fifth, present research results in several modalities to accommodate different communication styles. This will include both scientific research reports as well as plain language documents. One thing that we learned is that our engagement and compensation guide is not really in a plain language format. And so one thing that we need to work to do is to create a more plain language version of some of our public facing materials. This is something that we're learning how to do and considering as we move forward. Sixth, we need to compensate autistics for their time and experience, not just time spent in a meeting, but also preparation time and time spent considering the requests that we send to people through email. So all of those experiences and time that people spend are important and valuable to our process. Seventh, we encourage people to consult autistics regarding priorities for research and systems change. So you heard Brenna share that the research questions and the study design was influenced greatly by autistic involvement. It's not enough to have researcher developed questions, but to have a shared dialogue about what's important to the autism community to advance best practices. So what are we doing now? We have shared our compensation guide from our earlier project. We're now moving into a more comprehensive governance document that we're co-creating with our autistic partners. This includes a vision, principles, personal and professional goals of stakeholder partners, a decision-making guide, a communication plan, and additional measurement recommendations that are more formalized and structured throughout the study process. Our shared vision that we co-developed is to harness the personal and professional background and knowledge of each team member to contribute fully in the process of this research study in order to accomplish the study goal of reducing the rate of suicide among autistic youth and young adults aged 15 to 24 years. Our team then started to identify how we would do that through a series of principles. I want to acknowledge that our contributor, Lisa Morgan, recommended that we shift our language away from stating values, which are usually nebulous and somewhat unclear, to using the word principle to more clearly articulate what we will do as a result of our vision together. So these are examples of principles that we review during our study meetings, and we revisit to make sure that we are accomplishing them. Also important to our study team is to understand the personal and professional goals of stakeholder partners. And so for the roles that Brenna identified in the organizational chart related to our engagement core, including our community council and our multi-stakeholder advisory board, we want to know what the personal and professional goals are of partners so that we can tailor any activities in the study to those personal and professional goals. We've listed a few here, but we want to recognize that many of these goals are things that we need to embed additional things into our study in order to accomplish. So for example, for members who wish to contribute to publication and presentation, we need to thoughtfully consider how we might support that during our 5-year study and not just wait to the end to support people in thinking about contributing to authored publications. So what can we be doing in the next few years as we start this study to support people's authorship skills? That's something that our team is actively thinking about doing. And another example is to allow people to strengthen their skills in research and training. And so by helping people identify those goals and linking them with leadership opportunities to develop trainings and to lead those trainings in collaboration with others on the team, we are helping to accomplish these stakeholder goals. I'm going to turn it over to Sherry to describe our decision-making process.
Thanks so much, Teal. So in any research study, many important decisions need to be made, both when designing the project in the beginning and also throughout the project when we're executing it. Ensuring that these decisions, especially those that impact our aims or affect the safety of our participants, is really important that we're doing that collaboratively with our AASET partners. And we consider that to be a priority for our study team. So to achieve this goal, we thought it was best to develop a systematic approach to team-based decision-making. And I'm going to share that approach with you today. So in developing the approach, we were guided by a number of principles. And specifically, all members of our team are committed to taking into account the vision, principles, and purpose of the study when considering and making a decision. We're also all committed to addressing concerns directly in a respectful and non-public forum. And we make clear that if anyone needs help talking with someone they're working with or having trouble feeling comfortable, they need help being able to do that in a way that feels safe for them, they can reach out to any one of us at any time and we can work through it together. We're also all committed to being open to feedback and being willing to incorporate the feedback into our actions. So what does our decision-making process look like? Well, as a team, we came up with this 3-step process. So I'll first start with the big picture, and then I'll get into each of the steps individually to give you a better sense of what the process entails. So when we're considering a decision, so for example, whether to lower the inclusion age for participants or whether we'd like to add on a new recruitment site, we would start by having an open discussion of all potential options as a team. So that's step 1. Then in step 2, we would work to narrow down the options and vote to determine if we have each member's permission to proceed with a given option or options. And then finally, in step 3, we either finalize a decision or we return to step 1 if none of the options we've considered are considered acceptable at that point. So next I'll share some more detail about each of these steps, starting with step 1. So again, the goal of step 1 is to join together as a team, either by email or via virtual meeting, to discuss all possible decision options and to determine which, if any, options we want to eliminate at this point. So suppose we're considering again whether to lower the inclusion age for patients from 15, which is what it is now, and we're not sure which age to lower it to. So we might decide as a group that ages 11 and 12 are just too young, and we're not really willing to consider those options anymore. We take those off the table. But 13 and 14, might be possibilities, and so those stay in the running. So we can move to step 2, thank you. So in step 2, we work together to get a sense of how acceptable each of these options are to each of our AASET members. And the way we do this is by using a Google form to ask people to vote on each option individually. So in this case, in the example I shared, we would vote first on whether to lower the age to 13, and then we would separately vote on whether to lower the age to 14 as well to gauge people's comfort with each of these potential options. Then for each potential options, when people are voting, these are the choices that they see. So each AASET member would endorse for each option, whether 1, they don't have an opinion, 2, they prefer for this option to move forward, 3, they don't prefer this option but would be okay with it moving forward, or 4, they don't prefer this option and are not comfortable with it moving forward. And that then brings us to, so in this example here of age 13, lowering the eligibility age to age 13, this hypothetical AASET member does not feel comfortable with that option and they're not okay with moving forward, but they feel okay with lowering the age to 14 and endorse this with an option of 2 or a rating of 2. So in step 3, we work towards the goal of selecting a final option or determining whether it's necessary to discuss other options. So to accomplish this goal, Teal and Stephen, as the engagement core leads, review the Google form and share all the results with me and Brenna. So if necessary, we'll facilitate individual conversations with individual AASET members and discuss and I'll discuss that in a second when we get to the next slide about when and how that might happen. Okay. So when considering which option to endorse, all AASET members are aware that any of the first 3 options, so 1, 2, or 3, essentially means that they're giving us permission to proceed with that decision, that they're comfortable with moving forward with that, even if they're not, they don't prefer it. In contrast, though, option number 4 indicates that the member does not feel comfortable moving forward with this decision. And if this choice is selected by 1 or more members, we will not proceed further with the choice at this point. So the next thing we would do is consider whether there are any alternative options that are acceptable to everyone. And if that is the case, we would go with one of those options. If there's only one additional option that is acceptable, that default becomes the one we move forward. If there are multiple other options, then we choose the one that maximizes the number of 2 votes. Now, in the case when there's no other acceptable alternative option, then we will not proceed forward with that option. If any one member selects a 4, we're going to stop here. And what we would usually do is to discuss individually with the person or people who endorsed a 4. Now, our goal in doing this and having an individual discussion is not to try to convince that person to change their mind or to pressure them to join the other people who were comfortable with that decision, but rather the purpose of this discussion is to make sure that we're understanding the concerns of that member, and then also that we're making sure that if there's anything that we didn't communicate clearly, we give it another try and try to communicate it again to make sure that that option is clear to that person. Now, sometimes clarifying miscommunications may lead that AASET member to change their vote, and there are many other times when the option was clear and that person still doesn't feel comfortable with the option. And at that point, if we're on the same page about understanding that the person just is not comfortable with that option, then it is no longer considered. It's no longer in the running. And at that point, we would go back to step one. So when we start with the drawing board, we discuss other options as a team and move through that process again. So that is our decision-making process, and I'm going to turn it back over to Brenna to go through our communication plan.
Thank you, Sherry. And we just have a few more slides to share with you all today, and then we will open it up for questions. So we wanted to share a little bit more about our communication plan. We could, I'm sure, have an entire day workshop on this, since communication is such an important part of our partnerships and our collaboration. But to give you a very, very high level overview, here are a few ways that we are structuring our meetings with AASET to meet multiple types of learning styles and processing styles. So the first is we develop and share the meeting agenda in advance with the team. And so if people want to look that over ahead of the meeting, they have that opportunity to do so. One thing we've also been trying out the last few months is to share a recording ahead of time, so that any of the more kind of information heavy, where maybe one of us here really needs to share some details with the group and we're talking a lot, we can just go ahead and pre-record that and send that out in advance for people to watch on their own time, so that when we come together in real time over Zoom, we can have much more of a discussion. I know Teal mentioned this earlier about how much am I talking in a meeting versus really listening to everyone else, for example. So by pre-recording that and sending that out in advance with a transcript for people who want to read the words that we're saying in that pre-recording, it allows us to have more time for discussion during the live Zoom meetings. During the Zoom meetings and also after the meetings, we also encourage multiple ways to communicate and engage. And we try to remember to always say this at the very beginning of our meetings, and explicitly say that we encourage people to unmute and speak with their microphone, also to use the Zoom chat. We have some people who prefer to use the chat function, which is great, and we encourage that as well. And then we also, I know, have people who would prefer to have some additional time to think things over before sharing their thoughts. And so we always allow for that time after a meeting to follow up with thoughts, either by email or if someone would like to meet with us individually to share thoughts, we can do that as well. And then some of these accommodations and supports were already mentioned: closed captioning, the live meeting notes, someone to manage the chat as well, so reading aloud the written, the text-based responses or thoughts that are shared, and then our PowerPoint structure. As Teal mentioned, we are continuing to work on making things in plain language, putting things in plain language, having one idea per line. Stephen is very helpful with cutting out a lot of that unnecessary words that I know personally I will often add to slides and emails, and it's very helpful to just pare it down to what is the most necessary information to make this presentation or this email concise. And then one slide here just about measuring engagement. This is very important both to PCORI and then also to us as the research team, to see if we're doing this right and what can we learn as we're going about this. 5 years is a long time in a lot of ways. I think we're going to learn a lot and can continue to update how we're communicating and how we're engaging with our team to make sure we're doing so in the best way possible. And so Teal and Stephen have really been working hard on this, finding some existing tools that measure engagement and then adapting those to meet the needs of our group. We're in the process right now of getting some feedback on the questionnaire items to measure engagement from AASET, and then we'll be able to update that list of items and start using it on a regular basis. We're also getting their feedback on how frequently we should be measuring engagement, so I'm really interested to hear their thoughts on that. And then to wrap us up, I will turn it back over to Teal.
Thanks, Brenna. So to summarize what we have shared today, I think it's important to recognize that all of us have mentioned it's really important to acknowledge that none of us are perfect and we're on a constant learning process and journey to improve what we do together. And that if we all keep the goal and our vision in mind and recognize that we're trying to improve, that it's okay to make mistakes and acknowledge them and then work to change what happens in the future. So we try to be open and vulnerable to feedback, and it's an essential part of the learning process. We really aim to spend more time listening in our meetings. As Brenna mentioned, we try to ensure that those meetings are an opportunities for us to hear more from our autistic research partners about what their ideas are. And then just generally, we need to spend more time. This is an important part of planning for an authentic engagement process. It takes a lot of time to ensure that options are available to people, that members of the team are available to support conversations that occur outside of Zoom, or to produce materials that are accessible in multiple formats. So spending more time in the engagement process will result in overall better outcomes, we feel. But generally, this is an important part of any study or team that they should consider, is considering how much time it takes to do engagement in the way that meets everyone's needs. It's also important to throw out assumptions about what usually happens in research. And so everyone knows that research is generally a very highly structured scientific process, and there's certain expectations about what should happen in research. But I think we need to reframe who's the expert and how that expertise is involved in study design, development, and the ongoing process of the study. So I think there's some rigid assumptions about studies can't change once they've been proposed. Well, they can. They involve IRB changes, and it involves an openness to spend the time to make those changes. But those are some things that we need to be making sure that we don't rigidly adhere to. And then we need to recognize that systems are not created for stakeholder engaged research. So some of the conversations, in fact, a lot of the conversations that our team has are with university systems about how to make payment forms more accessible, how to make the process of training in human subjects protection more accessible, how to better communicate with our consultants on the study team from a university system approach. And these systems are slow to change, and we recognize that, but we're committed to working with those systems as well to make it better for the next group that comes through. And our last suggestion is to find allies and share good ideas. So many of these things that we've learned have been developed in partnership with other teams, and we've had mentors and guidance from many others, too many to name. But it is a collaborative process. It's not about keeping these ideas to yourself, so share those good ideas. And we'll flip past the publications that are available and open it up for questions, and your contact is valuable to us. Thank you.
Thank you so much, speakers, for an insightful presentation on suicide prevention interventions. This concludes the presentation portion and begins the Q&A session of today's webinar. As a reminder, you can submit your questions through the questions pane in your control panel. Because our time is limited, we may not be able to get through all of your questions. If there are any questions that we did not get to today, we will try to get back to you by email. So our first question is, what are some strategies for working with such a large team?
That is a wonderful question. I will let's let Sherry kick us off with that one. Sherry, do you mind?
Sure. Thanks for that question. When we were first making that organizational chart that Brenna shared, I would get palpitations every time I looked at it because there are so many people involved in it. It seemed a little bit overwhelming. But in the end, I think that chart kind of served as our blueprint, and we go back to it to remember where each member of the study team kind of fits in. And we've worked together to define the roles of each team and each member. So hopefully that's really clear. And we can use those roles as an organizational kind of guide. And we meet with certain people together as a team. Sometimes we bring certain teams together. And by having those buckets, it just kind of helps us stay on top of making sure that nobody's getting left out of the communication process. We are also, I'll speak for myself when I say I feel really blessed to have a principal investigator, and to be able to work so closely with Stephen and Teal as the co-leads of the engagement core, and having none of us have to do this all on our own has really helped us to be able to both divide and conquer to ensure communication with everybody, but also to come back together to make sure that we're kind of getting input from everybody and are always kind of collaborating with our larger team. So I'll stop there, and in the spirit of collaborating, I'll see if anyone else wants to add anything that I left out.
Thank you, Sherry. I know we didn't have time in today's presentation to go through each part of the newer governance document that Teal described, sort of building off of the engagement and compensation guide from AASET. But part of that governance document, I don't remember how many pages, but it's a good number of pages. We have the roles and responsibilities, like Sherry was just talking about, spelled out in detail. And I think that came from early conversations. Correct me if I'm wrong, Stephen and Teal, but some of our AASET collaborators said it would be really helpful to have those very detailed documents about what the roles on these different teams may look like. And I think that's been very helpful to refer back to, particularly because some of our collaborators are on multiple teams, right? So they are on the clinician training team and the study staff training team and the community council. And so kind of keeping some of those roles and responsibilities straight, it's been helpful to have a document to refer back to. Stephen,
you're absolutely right, Brenda. In terms of, that's one of the 4 C's that we have in the compensation engagement guide, and that is clarity of communication, and as clearly as possible describing what we're all doing, and that also helps us see where we fit into that huge organizational chart.
Absolutely. Teal, anything you wanted to add to that one?
You guys hit everything. I have nothing to add.
Great question. Thank you.
Thank you all. All right, our next question is AASET available for consultation on existing or planned anticipated research projects?
I will turn that one over to Stephen and Teal.
All right, Teal, do you want to start and I'll fill in?
Sure, that sounds good. We are happy to collaborate with others in terms of study ideas, and we always involve our AASET members in asking whether or not they would like to be involved. So Stephen and I wouldn't be making that decision alone. We would really want to put it to the team and find out what their thoughts are. But materials that we develop and share are publicly available, and we would encourage you to find those, and would definitely be open to a conversation. The more that we can promote these collaborative approaches would be a huge improvement in autism research. Stephen?
Yeah, and that's another, that we can even include that as a 5th C, and that is collaboration. And it is with that collaboration with the community council, which has sometimes caused us to change in midstream how we're conducting our research. So for example, we were planning to gather data via Facebook. And then there was a lot of, there were questions as to the security of data and confidentiality of data on Facebook, and the community council was getting rather riled up about it. So we had a discussion, and we decided to get our information through other channels. And the key is that for that research, it was not Teal and I running the research, but it was in collaboration. And if that is what the community council wanted, then it was our duty to make it happen.
Great question.
I cannot speak highly enough for collaborating with AASET. So that's a great question.
Thank you, everyone. So the next question actually comes from a group that's watching all together at UNC. They have a question about the use of the 1, 2, 3, 4 voting system and how you came to the decision about using that versus an average across the team.
That's a really good question. Let's see, Sherry, do you want to talk a little bit about that and we'll all fill in?
Yeah, I'm trying to remember if we considered using an average. I don't know that we did. We definitely came up with this process over, a number of weeks through many different discussions, first with our smaller group, and then we brought it to AASET for feedback, and we refined it over time. I think it was important for us to have a system that allowed, or actually that didn't allow, any decision to proceed if any one member felt uncomfortable with it. So I think that that's why we included that item number 4, and that's why that item is treated differently than the rest of the items or the rest of the choices, because we really wanted to make sure that whatever decisions we pursue are going to be okay with everybody, that nobody is going to be feeling like uncomfortable with the decision that we're making. So I think that might have gotten lost in an average system if we using an average system. And that's one of the reasons why we developed this somewhat complicated, but it's still working decision-making process system. I will bunt it to Teal in case you have anything else you wanted to add.
I think you did a great job, Sherry. Yeah, I think an average would have lost the value in people being able to express discomfort with the decision. And that was, like you said, a clear and important and a meaningful reason for having that. I think the other point that we want to emphasize is that in the absence of a 4, an average may not get at what most people think is the preferred option, which are 2s. And so we do want to maximize the 2 votes, which is I prefer this option to proceed, whenever there isn't a 4 that's in the mix. And so we don't want to, we don't want to think about an average as the best choice for every decision. And really look at the contextual nature of how many votes we got for each of those options. So Stephen and Brenna.
Well, what this does is it really enables, it empowers every voice to be heard and every voice to be given proper consideration. And even though it may take longer to get through than a simple average, it also assures that everybody feels that they've been heard, and when everybody feels that they're authentically included, instead of, for example, one person says absolutely not, I don't agree with this, and then they get felt left out due to just taking an average, that solidifies the buy-in of the autistic community and the community council in general.
Absolutely. I would just add, I agree with all of that. We did talk a lot about this, I think, as Sherry alluded to, not just the 4 of us, but with all of AASET, because we wanted to make sure that, one, that these choices make sense and are the best for this group, and that the wording as well felt right. And I do think we had to make really clear the difference between a 3 and a 4, right? We understand that sometimes we're going to move forward with things that not everyone is super excited about or maybe prefers. But if it's a 3, if it's a I don't prefer this, but I'm okay with it moving forward, that is very different than a 4 of I do not feel comfortable with this. So I think there were some helpful discussions early on. And again, an average would kind of lose that, right? Do you not feel comfortable at all with it, or are you okay with it, but it's just not, maybe not your top pick? And then the wording as well. And, you know, of course, we're not the first team to put together a shared decision making process or guidelines like this. And we did consult with existing procedures that are out there. We talked with AASET about things they've liked and maybe not liked from other types of shared decision making in ways that gets voted on, and try to make sure that the wording felt right as well. So I'll just give one concrete example around that. I don't know if you all may be thinking about this too. At first, for that vote of 4, it said something like, I can't live with this choice. And we felt like that did not feel right, particularly in the context of a suicide prevention study, to be using that type of terminology. And so working with AASET to think about what's a really clear way of wording these options that also feels respectful. So it was really collaborative, and definitely learned a lot about what people would like and would not like in a shared decision-making process. Great question from UNC. Thanks.
Thank you. The next question is, how can I go about finding allies related to, you know, the last slide on some things to keep in mind, finding allies and sharing good ideas?
Stephen, I would love to hear your thoughts on that one.
Oh, sure. So in finding allies, it means you have to reach out to the autistic community. And we can be reached by this, one way is via disseminating the work that we're doing at conferences such as the International Society for Autism Research, that's INSAR. There are many autistic people there who are fascinated and are actively involved in research by connecting with autistic-run organizations such as GRASP or the Autistic Self-Advocacy Network. And also, there are also some more mainstream organizations such as Autism Speaks. Even though Autism Speaks is controversial in the autistic community, they have been making great strides and putting forth great efforts to be more about working with autistic people as opposed to doing things to autistic people. So these are just a few of the ways that you can reach out to the autistic community and also organizations that benefit the autistic community.
Thank you, Stephen. Teal, would you add anything to that one about fives?
No, supporting what Stephen said, there are a number of groups that are in development or in early stages. The Autistic Researchers Group, as Stephen mentioned, is a group that's through INSAR, and there's other groups that are developing as well. And so you can reach out to any study teams that have community driven research. So our team is only one of many, and ask how to get connected. But you can also find those through organizations, as Stephen mentioned.
Oh, another organization is the Participatory Autism Research Collaborative out of the United Kingdom as well. So this is an international effort, just as our community council is internationally represented.
Question, thank you.
All right, and I think that, yeah, that's all the time we have questions for. So thank you, Drs. Shore, Benavidez, Maddox, and Yeager-Hyman. Thank you all again for taking the time to share information about AASET's collaborative work and describing effective practices for including key stakeholders as research partners. And thank you to everyone for joining us today. Once you close out of the program, you will receive an exit survey. Please complete that to let us know what you think of today's event. Everyone will receive a follow-up email to today's recording with a link to view it and the materials within the week. On behalf of the Organization for Autism Research, thank you so much for joining us and have a great rest of your day.
Thank you.
Bye-bye. Thank you.